So time-limited therapy is a little bit strange term in CLL because before the use of targeted agents, all therapies were actually time-limited. When we used chemotherapy for all patients, we were not able to give more than, well, mostly 6 cycles because of toxicity reasons. Then we had the novel agents, specifically BTK inhibitors, Ibrutinib being the first one, which, and also Idelalisib, which were and are very good drugs, but those drugs as single agents you cannot stop. If you stop, the disease very rapidly comes back, and the reason is that actually you don't kill your CLL cells directly, but what you do is you prevent the cells from going into this lymph node niche where they get kind of revitalized. Well, of course, there are disadvantages of continuous therapy. Is although the side effects might be mild, it's still you still have side effects, and if you have side effects for very long periods, even mild side effects can become very cumbersome. The second is that it's expensive. Those drugs are expensive, and if you can't stop the treatment until years to come, then of course it's the price will get very high. And the third thing is that if you treat somebody until relapse, you know one thing for sure, and that is that you create resistance in those cells for that specific agent, and you lose that activity of that agent. And indeed, that has been shown both for the BTK inhibitors, but also for the BCL2 inhibitors, that specific mutations can occur which prevent the cells from, prevent this drug from being active. So after that, many trials are and have been shown that if you make smart use of different categories of treatment, can be novel agent and novel agent, like BTK and BCL2 inhibitors, can be inhibitors like BCL2 with a specific antibody. We also have now seen studies from Matthew Davis, for instance, where he combines chemotherapy with novel agents. But all this gives rise to the possibility to have very good and deep remissions, but reached in a limited period of time. So you can stop treatment. And the advantage of stopping treatment is not only, again, the cost and the side effects, but also that, and that's still a promise, but early data show indeed that it's possible, that you can retreat patients when they relapse after a hopefully long period of being without any drugs, that you can give the same treatments again, maybe in a somewhat different combination. Now, the first studies, like the MURANO study was the first one, showed that indeed, if you give a time-limited treatment, fixed duration, 24 months in relapse patients, you're done. And after that, studies came with targeted agents in the first-line setting, 12 months, which seem to be very good. And I think the next goal to reach is that you don't treat all patients if they're one and the same, but that you can look for biological markers to see, well, this patient needs maybe longer treatment, this patient do exactly as well, or even better with less cycles of treatment. So you can really make a tailor-made treatment there. And so far, MRD, minimal residual disease measurements, seem to be a very powerful way of doing this. But we're still learning that, and maybe we have to combine different methods to see whether or not we can go for a patient-specific treatment duration.